Hello, welcome to this presentation of Describing a Disease Project. Both Armani Hall, Viviana Macias, and I, Gisalba Anna, will be presenting the disease anthrax.
Anthrax is caused by a gram-positive spore-forming bacteria known as Bacillus anthracis. Although it is speculated that the earliest sickness throughout the history were caused by anthrax due to the similar symptoms that occurred, it was not until 1752 and 1769 that anthrax was fully confirmed to cause disease in clinical setting. By the end of the 20th century, there was an annual incidence rate of 2,000 cases worldwide.
Bacillus anthracis is both a primary and facultative pathogen.
It does have the presence of a vector, as insects can acquire the pathogen by interacting with infected animals such as cattle and then transmit it to humans cutaneously. There is a variety of entry routes into a human host. For example, the spores of the pathogen can be acquired through inhalation, cutaneously, injection, or the gastrointestinal route. The cutaneous route is the most common form of anthrax infection, but is considered to be the least severe of the entry routes. However, inhalation of spores is the most deadly form of anthrax. Both the gastrointestinal and injection routes are the least common, and in fact the injection route has never been reported in the United States. Regardless of its entry route, the pathogen can result in severe circumstances as it can go systemic. The symptoms of anthrax depend on the entry route of the pathogen and can develop between 1 day to 2 months.
For example, cutaneous anthrax symptoms include small blisters that may swell and become itchy and then develop into a painless sore with a black center. On the other hand, inhalation anthrax may include fever and chills, shortness of breath, excessive sweating, and body aches. Those most at risk are people such as veterinarians who interact with domesticated animals in which are already infected, people who handle animal products, travelers who come in contact with airborne spores, and laboratory professionals who work with the pathogen itself. Nonetheless, all entry routes of anthrax pose a risk of death, especially if it is left untreated, as it can go systemic.
The famous case of anthrax occurred about 1 week after the 9/11 attack in the United States. There was mail laced with anthrax spores arriving at various locations, including news media companies and the Congress offices. This was a very big deal, as not only was it bioterrorism attacks on the United States, but also the first case of inhalation anthrax since 1976. The impact of the attack were 5 deaths, 43 confirmed cases of anthrax exposure, and 10,000 people now at risk of overall exposure.
Nonetheless, after this famous attack, social awareness of bioterrorism in general became focused on, and a combination of FBI and genetic research action was taken to not only advance modes of bioterrorism identification, but also the source of this attack specifically. Bacillus anthracis is a cellular pathogen from the bacteria domain and again a part of the gram-positive division in Firmicutes phylum. This pathogen is zoonotic as it has the ability to produce inactive spores that can live in the environment for long periods of time, but then become activated as they get into the bodies of their primary host reservoir, that is, domesticated animals, who can then transmit the disease to humans, their side host. Given that anthrax can be acquired in a variety of ways, it can be diagnosed with an X-ray or CT scan, blood agar test, skin lesion swab, gram stain, spinal tap, or antibody and toxin measurements. The X-ray and CT scans are specific in the inhalation anthrax as it allows to visualize fluids buildup between the chest and lungs of a patient, or even widening of their chest due to enlarged lymph nodes. By using the blood agar test, one can be quickly diagnosed, as when infected, their sample will grow in a grayish-white and non-hemolytic manner. Spinal taps are most important in diagnosing if the infection has gone systemic. Upon diagnosis, anthrax can be treated with a variety of antibiotics such as penicillin, ampicillin, and first-generation cephalosporin. However, there has also been clinical research and testing in regards to utilizing AVP 21D9, also known as Thorvixa, as a mode of treatment. Thorvixa is an anthrax antitoxin that has proven to increase the survival rate of anthracis-infected rabbits and macaques up to 92% and 67% respectively. Most importantly, when infused into human volunteers, the antitoxin was well tolerated and did not lead to any severe effects. Similarly, raximacubub has been studied for its anthrax preventative properties. Raximacubub is a monoclonal antibody specific to the protective antigen of the anthrax toxin. This preventative agent proved to be effective as it increased the survival rate for both monkeys and rabbits at each of the administered dosages before infection. Antibiotics have been the primary course of action to not only treat anthrax infections but also prevent the spread of the disease. However, clinical research has proven the importance of agents related to raximacubub since they too can be preventative in the disease and its high morbidity rates, as they can be administered prior to infection when one is skeptical of potentially being exposed to the pathogen. Thank you for listening, and we hope you enjoyed our presentation.